So I'm going to speak about current concepts regarding antiplatelet therapy. I thought I'd get this slide out of the way early. So I do have a disclosure, which is that one of my primary research interests is in antiplatelet therapy and platelets, and I find this sort of thing fascinating. But don't worry, I am a clinical cardiologist, and I'm going to try and give a relatively straightforward talk with just going through some of the basics of the data that I think is potentially practice changing, and going through some of the guidelines and what we do in clinical practice in Europe and the UK. So we've already had a masterclass on aspirin, which you can see at the top, working on one of what is only one of a multitude of platelet receptors. One of the most important platelet receptors in terms of current treatments and changes in current therapy is the P2Y12 receptor that you'll see over on the right-hand side, which is a therapeutic target for many of the drugs that you will have seen in recent clinical studies, and I'm going to go through some of those. I'm also going to briefly mention glycoprotein inhibitors, which work on the platelet glycoprotein complex down in the bottom right. And what I want to achieve during this lecture is I want to, hopefully at the end, give you an idea of what to give in terms of antiplatelet therapy, when to give it, and how long to give it for. And I'm going to talk about three specific subsets of patients. Firstly, patients who've had stents for stable coronary artery disease. Secondly, patients with non-ST segment elevation acute coronary syndromes, and thirdly, ST elevation infarcts. But first, just to go through a little bit of the background data. So why are platelets important? Well, platelets are an integral part of the pathogenesis of acute coronary syndromes. So a ruptured or fissured plaque leads to platelet adhesion, platelet activation, platelet aggregation, and that leads to thrombus formation. And that thrombus formation can go on and occlude an artery and cause an ST elevation infarct, or cause smaller thrombuses, or affect smaller arteries and cause a non-ST elevation acute coronary syndrome. As an interventional cardiologist, we're also particularly concerned about stent thrombosis, not only because it's associated with significant morbidity and significant mortality, but also as we take it as a personal insult that what we've done has gone wrong. Stent thrombosis has multiple etiologies. So there have been huge advances in percutaneous coronary intervention in terms of how we implant our stents, which have had significant effects on reducing stent thrombosis. There are also systemic conditions, which you can see here on the right-hand side, like diabetes, malignancy. I would probably add smoking to that list. But as well as those conditions, there is absolutely no doubt at all, and our group and many others around the country have shown a strong association between stent thrombosis and high platelet reactivity. So platelets which are still highly active despite antiplatelet drugs. So, how can we modify platelet adhesion, activation, and aggregation? Well, we've got a whole host of different targets on the platelet surface, and we've got a whole host of potential drugs. We've just had that lecture on aspirin. I can assure you that there is a similar amount of data on most of these drugs which are mentioned here, and I'm not going to go through all of it today. I will briefly talk about some of the thienopyridines, specifically prasgreland and the landmark trial, the TRITON-TIMI 38. I'll also briefly mention cangrelor, which got its FDA approval just a couple of weeks ago. And I will talk a little bit about the Plato trial, which was the landmark trial on ticagrelor. Aspirin. Luckily, I don't have to say much about aspirin. I don't think there's much controversial about the use of aspirin in acute infarcts or in patients undergoing stenting procedures. So I'm going to pass by aspirin. Clopidogrel. So Clopidogrel has transformed the practice of interventional cardiology and acute cardiology and acute coronary syndrome management. And we have a whole wealth of data on Clopidogrel. In STEMI, the most important trials are the TRITON-TIMI 28 trial and COMMIT. We've got trials in PCI, percutaneous coronary intervention, with the PCI arm of the CURE study and the CREDO study. And then we've got the CURE study in acute coronary syndromes. CURE was really a transforming practice study. So this was a study in fairly unselected acute coronary syndrome patients who were randomized to either clopidogrel or placebo in addition to aspirin. It was back in the day where there was a pretty non-interventional approach to acute coronary syndromes. Patients didn't get any sort of intervention particularly early, including the clopidogrel. They certainly didn't undergo PCI early in the course of their admission, and only a very small group did. But what it showed was a highly significant 21% relative risk reduction in this primary endpoint of cardiovascular death, myocardial infarction and stroke. And this really transformed practice. However, there are the new kids on the block, prasgreland and ticagrelor, and they have some important differences to clopidogrel. And I just wanted to very briefly go through some of the data with these drugs. In the UK, we're very lucky. We've got the NICE system, National Institute for Clinical and Healthcare Excellence, which is now called, which gives us advice on how to use these drugs. But why? So firstly, what are the differences between these new drugs and clopidogrel? So this is some of the early pharmacokinetic work looking at prasgreland and clopidogrel. So if you look at the graph on the left-hand side, you will see the response measured using platelet optical aggregometry to a clopidogrel loading dose on the bottom with the coloured-in circles, and a prasgreland loading dose on the top. And what this shows is that with prasgreland you get a far more rapid, a far more profound, and with the smaller error confidence intervals, a far more reproducible anti-platelet effect than you do with clopidogrel. And if you look at the graph on the right-hand side, which really just shows it in a different way, this is responses in volunteers given a loading dose of clopidogrel, showing a very, very marked heterogeneity in response. In fact, that grey area down the bottom really means that those patients in that group, there is no discernible effect on platelets at all, in about a third of people who you give clopidogrel to. If you compare that with the patients given prasgreland over on the right-hand side, you see on the whole, more profound and a much more reproducible and reliable antiplatelet effect. This is a similar pharmacokinetic data for ticagrelor, which really looks remarkably similar. Again, a far more profound, rapid, and reproducible effect with ticagrelor, to the extent that you get roughly the same platelet inhibition half an hour after ticagrelor as you would 6 hours after a loading dose of clopidogrel, and about twice the antiplatelet effect after an hour. This is the landmark trial on prasgreland, the TRITON-TIMI 38 trial. This was a very large randomized trial of prasgreland versus clopidogrel in acute coronary syndrome patients. This is the cardiovascular, combined cardiovascular endpoints of cardiovascular death, myocardial infarction and stroke. And what you can see is really a very early separation of the curves, with then pretty much the same separation of the curves extended out to a year. And this showed a 19% relative risk reduction in that primary endpoint. However, this came at an increased risk of bleeding. These drugs are more potent. They are good for cardiovascular endpoints, but they come at a cost. The TRITON-TIMI 38 investigators took a slightly unusual step of publishing subgroup analysis at the time of the initial study, and they identified several cohorts of patients who were at particularly high risk of bleeding, such as the elderly, patients with low body weight, and particularly people with previous transient ischemic attacks and strokes. They also identified some groups who did particularly well with prasgreland, and the one that stands out is diabetics. This is, as you can see, a fairly similar graph for the Plato study, which was the landmark trial on ticagrelor, published a few years later. There were some important differences. So again, a very large randomized trial of ticagrelor versus clopidogrel, whereas in TRITON-TIMI 38, most of the antiplatelets were given at or after the time of coronary angiography or intervention. In Plato, they were given up front. But despite that, you'll see a slightly more gradual separation of the curves, although they do seem to still be slightly separating up to a year. And again, there was a highly statistically significant 16% reduction in the overall primary cardiovascular endpoint here of cardiovascular death, infarct, and stroke. So that's some of the data. What do we do in practice in the UK? So elective stenting is probably not the most controversial area, so I'll get that over and done with first. So we give everyone aspirin. If there have been previous reactions to aspirin, we will try and desensitize them to aspirin, which we can successfully do in about 98%. We would give 75 milligrams of aspirin daily. And we will then give a P2Y12 receptor antagonist. Almost all of our elective patients will get clopidogrel. It is off license, it's cheap, easily available, and relatively safe with less bleeding. However, there are a couple of subgroups which we would probably treat a little differently. So subgroup analysis of Plato, which they didn't do at the time of the initial study, suggested particular benefits from ticagrelor in people with renal failure. So there's a good indication for ticagrelor in patients with impaired renal function. And as I said, prasgreland, very good data if you're diabetic. When would I give them? Well, I'd give them as soon as I knew that I was going to go on and stick in a stent, even if that was weeks down the line. I don't think there's any point in waiting. I would far prefer to know before I go and put in a stent if they're going to have a problem with their antiplatelet therapy rather than find out afterwards. And how long would I give them for? Well, aspirin, I give lifelong, and the P2Y12 receptor blocker for a bare metal stent, a month. And for current drug-eluting stents, I would give a 6-month course of dual antiplatelet therapy. What about non-ST elevation acute coronary syndromes? Well, potentially this is a little bit more controversial. Initially, I would want an aspirin loading dose. We give 300 milligrams in the UK, but at least 300 milligrams. I don't think there is any benefit from giving it intravenously rather than orally. It has extremely good oral bioavailability. And then we would also give a P2Y12 receptor blocker. And European guidelines certainly suggest, I'll show them in a moment, that we should be giving ticagrelor or prasgreland, one of the new, more potent oral P2Y12 inhibitors rather than clopidogrel. The only subgroup where I would definitely give clopidogrel is in people with a history of previous TIAs and strokes. I mentioned the subgroup analysis in the TRITON-TIMI 38 trial. They didn't do one in Plato, but that's not to say that if you don't look carefully at the data, there isn't a slightly worrying signal with an increased risk of fatal intracranial hemorrhage in people with previous stroke in Plato. But also tend to avoid ticagrelor in severe conducting system disease. It does have some adenosine-mediated effects, and we've certainly seen patients develop heart block on ticagrelor. And there is no indication for prasgreland in medically managed patients. These are the European guidelines, and I'd just like to highlight the point by saying here that they, you probably can't read it, but they say that clopidogrel is only indicated if you can't give ticagrelor or prasgreland. As well as our oral drugs, we still do use glycoprotein inhibitors. We tend to use apixaban in the UK, and we would use them as bailout during PCI. I looked at our latest data. We are now using it in less than 2% of our non-ST elevation acute coronary syndromes, but times where we might use it is if there's massive visible thrombus for no reflow in vein grafts, and if there were side branch issues. So that's what to give, but when do you give these drugs? And I think it very much depends on your strategy. So original studies like CURE were effectively non-interventional studies. We really have very, very little data on when we should be giving, particularly these new, more potent oral P2Y12 receptor antagonists. And my suggestion is that if you are proceeding to a fairly early angiogram, by which I mean within 48 hours of presentation, there is no role from loading them on oral antiplatelets other than aspirin prior to doing the angiogram and deciding whether they need intervention or not. If, however, it's going to be several days until they have their angiogram, I think there is a role from giving them up front. Why is this? Well, as I said, there's really very, very little data. The best data probably comes from this study, which is the COAST study, which is a study of about 4,000 patients randomized to sort of semi-preloading with prasgreland compared to a full dose of prasgreland after the time of coronary angiography when your strategy is known. This is a primary efficacy endpoint looking at a combined endpoint, not only cardiovascular death, heart attack, strokes, but also unplanned revascularization and bailout use of glycoprotein inhibitors. This is without pre-treatment, so prasgreland 60 milligrams after you've done the angiogram. Literally on the table, they tend to crush it up and give it with a sip of water just before you go on and put your stent in. And that's with pre-treatment. Absolutely no difference in the primary efficacy endpoint. And preloading seems to come at a bit of a cost. So this is with no pre-treatment. This is TIMI major bleeding. And that is with pre-treatment. So pre-treatment effectively doubles the risk of TIMI major bleeding. So no real benefit, comes at a cost. If you can get on and do the angiogram within 48 hours, I don't think there's any role from giving them up front. How long should you give dual antiplatelet therapy for after an acute coronary syndrome? Well, again, this is a slightly contentious area. There's been a wealth of data over the last 12 months or so. This is the DAPT trial, which you've probably all heard of, a large randomized trial randomizing patients to either 12 or 30 months of dual antiplatelet therapy. It's important to remember that they only randomized patients after they had successfully tolerated dual antiplatelet therapy for 12 months. So probably relatively low-risk patients, both in terms of an ischemic endpoint and in terms of bleeding. What this trial showed was that there was undoubtedly a benefit in terms of reducing ischemic complications, particularly stent thrombosis and recurrent myocardial infarction. But again, as you would expect, these came at the cost of increased bleeding. So what's our current practice? Well, aspirin lifelong and dual antiplatelet therapy for a minimum of 12 months. However, I think you can vary this both ways. And if there is a very good indication for cessation or interruption of dual antiplatelet therapy before 12 months with current stents, I think that is on the whole very low risk. And if people in particular have a very low bleeding risk, I don't think there is a downside from continuing dual antiplatelet therapy for longer. There is just a possibility, however, that all that the DAPT trial has shown is that rather than actually preventing recurrent events long-term, you just delay them. And there does seem to be an increased risk of recurrent events in the few months after cessation of dual antiplatelet therapy, whether it's at 12 months or 30. What about STEMI? Well, again, don't forget the aspirin, at least 300 milligrams. Most people in the UK seem to have some in their cupboard at home, which they'll have taken if they think they're having a heart attack, but as early as possible. And again, one of the modern, more potent oral P2Y12 receptor blockers, either prasgreland or Ticagrelor. So Cangrelor has just received its license from the FDA. It has some huge potential benefits in that it is almost instantaneously acting intravenous drug that you can just connect up in the cath lab, but we'll have to see what place it has. In terms of glycoprotein inhibitors, we use it as bailout only in terms of primary angioplasty. We just use unfractionated heparin, dual oral antiplatelet therapy, and then give abciximab as bailout, and we use it in less than 10% of our primary PCI. It is certainly very reasonable and supported again by the European guidelines to give a glycoprotein inhibitor upfront in people with ST elevation infarcts who present early, typically within 3 hours of the onset of symptoms, and who have a relatively long transfer time until they're going to get their primary PCI. When do you give these drugs? Well, certainly in terms of the oral drugs, as soon as possible. Preferably pre-hospital, and that means both aspirin and, if it can be organised, prasgreland or Ticagrelor in the ambulance. These are the European guidelines, which basically just say exactly what I've said, just proving that we're not outliers in the UK. And how long do you carry on with dual antiplatelet therapy? Well, really exactly the same rules apply as for non-ST elevation acute coronary syndromes. So aspirin lifelong and dual antiplatelet therapy for 12 months, although I think there is a license now to either increase that duration in people who are at particularly low bleeding risk, or to interrupt or stop dual antiplatelet therapy before 12 months, for example, for things like essential surgery or if there is a major bleeding event. So, in summary, what do we do in the UK? What is the current way we manage antiplatelet therapies? Well, in elective stenting, dual antiplatelet therapy with aspirin and usually Clopidogrel for 1 month for a bare metal stent and 6 months for a drug-eluting stent. In non-ST elevation acute coronary syndromes, well, I think Clopidogrel is on the way out. We would use a potent oral P2Y12 receptor antagonist, so either Ticagrelor or prasgreland. And if we were proceeding to an early invasive strategy within 48 hours of the patient's admission, I do not think there is any role from giving it up front. I would give it once I had seen the angiogram and knew I was going to go on and do stenting. If, however, that angiogram was going to be delayed for several days, I would give them dual antiplatelet therapy as soon as they came into the hospital door. And I would then carry on with dual antiplatelet therapy, as I've said, for 12 months, plus or minus, largely depending on whether they have a bleeding event, in which case I think it is reasonable to stop it sooner, or a low bleeding risk, in which case I think it's okay to carry on with it longer. In ST elevation infarct, aspirin and one of the new potent oral antiplatelets, Ticagrelor or prasgreland, as early as possible, no delay. And again, I would carry on with it for 12 months plus or minus. And we would still use glycoprotein inhibitors as bailout during angioplasty for people in whom, for example, they can't take oral tablets, for whom, if they're intubated and ventilated, for example, and possibly during transfer for primary PCI. However, I suspect that glycoprotein inhibitors' days may well be numbered with the introduction of Cangrelor, which I suspect will be used for some of those indications instead. Thank you very much.